Ladies and gentlemen, esteemed colleagues, and eager learners, welcome to today's lecture on a topic that is as profound in its impact as it is intricate in its presentation, the phenomenon of stroke. Stroke is more than a medical condition, it's a life-altering event that touches the very essence of human existence, affecting not just the individuals it strikes, but also the tapestry of families and communities woven around them. A stroke is a vascular injury that diminishes cerebral blood flow to a specific region of the brain, resulting in neurological impairment. It is a sudden event that demands immediate attention, where every second counts. Accurate determination of the last known time when a patient was at their baseline, functioning normally, is essential. This timing is crucial for treatment decisions that could mean the difference between recovery and lifelong disability. In-hospital mortality rates starkly illustrate the gravity of this condition, 5 to 10% for ischemic strokes and a staggering 40 to 60% for hemorrhagic strokes. Only a mere 10% of stroke survivors will recover completely, underscoring the importance of understanding, preventing, and effectively treating this ailment. Ischemic stroke, the silent blockage. Let us delve into ischemic strokes, which account for 87% of all stroke cases. Ischemic strokes are primarily caused by obstructions within the blood vessels supplying blood to the brain. These obstructions can be classified into thrombotic and embolic causes. Thrombotic causes 80% of ischemic CVAs. Thrombotic strokes often stem from atherosclerosis, the buildup of plaques in arterial walls, narrowing the vessels, vasculitis, inflammation of the blood vessels, vertebral and carotid artery dissection, tears in the inner lining of these arteries, often precipitated by activities like yoga, spinal manipulation, coughing, or vomiting, polycythemia, an increased concentration of red blood cells, thickening the blood, hypercoagulable states. Conditions that increase the risk of blood clot formation, such as the use of oral contraceptives, antiphospholipid antibody syndrome, protein S and C deficiencies, and sickle cell anemia, infections and toxicologic exposures, including substances like cocaine and amphetamines. Embolic causes 20% of ischemic CVAs. Embolic strokes are caused by valvular vegetations, growths on heart valves that can dislodge and travel to the brain, mural thrombi, clots that form in the heart chambers, arterial to arterial emboli, for example, in amaurosis fugax, where an embolus from a proximal carotid artery plaque travels to the ophthalmic artery, causing transient monocular blindness. Fat emboli and septic emboli, particles that occlude cerebral vessels, hypoperfusion and cryptogenic strokes. Hypoperfusion strokes result from systemic hypertension due to cardiac failure, leading to inadequate blood flow to the brain. Cryptogenic strokes, on the other hand, are enigmatic. They are ischemic strokes of unknown origin. Transitory or reversible, reminding us of the complexities that still elude modern medicine. Hemorrhagic stroke, the ruptured vessel, accounting for 13% of strokes. Hemorrhagic strokes are caused by bleeding within the brain tissue or surrounding spaces. They are categorized into intracerebral and subarachnoid hemorrhages. Intracerebral hemorrhage causes include hypertension, the most common cause, leading to weakened blood vessels that rupture, cerebral amyloid angiopathy, typically found in the elderly. This condition causes amyloid deposits in the vessel walls, leading to lobar hemorrhages, anticoagulation, medications that increase bleeding risk, vascular malformations, such as arteriovenous malformations, AVMS, and Moyamoya disease. Cocaine use, a potent vasoconstrictor that can lead to vessel rupture. Subarachnoid hemorrhage, this occurs due to berry aneurysm rupture, congenital weaknesses in vessel walls that burst, arteriovenous malformations, abnormal connections between arteries and veins. Clinical features, mapping the territory of the brain. Understanding the clinical manifestations of stroke requires a journey through the cerebral vasculature, recognizing how each artery's occlusion presents uniquely. Internal carotid artery, tonic gaze deviation, the eyes deviate towards the side of the lesion. Dominant hemisphere lesion leads to global aphasia, dysgraphia, dyslexia, dyscalculia, and disorientation. Non-dominant hemisphere lesion results in spatial or visual neglect. Anterior cerebral artery, ACA, contralateral sensory and motor symptoms, predominantly in the lower extremity, sparing the hands and face. Incontinence, urinary and bowel. Left-sided lesion may cause akinetic mutism and transcortical motor aphasia. Right-sided lesion can result in confusion and motor hemineglect, primitive reflexes, presence of grasp and suck reflexes, gait apraxia, difficulty initiating walking movements. Middle cerebral artery, MCA, hemiparesis and facial plegia, sensory loss contralateral to the affected cortex, more pronounced in the face and upper extremity. Aphasia, if the dominant hemisphere is involved. Wernicke's aphasia, receptive aphasia where comprehension is impaired. Broca's aphasia, expressive aphasia where speech production is affected. Non-dominant hemisphere involvement leads to dysarthria without aphasia, inattention, and neglect of the side opposite the infarct. Contralateral homonymous hemianopsia, loss of the same half of the visual field in both eyes. Gaze preference, eyes deviate toward the side of the infarct. Agnosia, inability to recognize familiar objects. Posterior circulation, supplied by the vertebral arteries and their branches, AICA, basilar artery, PCA, and pica. The posterior circulation presents with cross-neurological deficits, ipsilateral cranial nerve deficits with contralateral motor weakness, multiple simultaneous complaints, including loss of consciousness, nausea, vomiting, alexia, and visual agnosia, the 5DS, dizziness, vertigo, dysarthria, dystaxia, diplopia, and dysphagia. Aortic dissection association, approximately 25% of cases, basilar artery, severe presentations, quadriplegia, coma, or locked-in syndrome, crossed signs, unilateral cranial nerve deficits with contralateral hemiparesis and hemisensory loss. Suggesting brainstem infarction, specific syndromes, Millard-Gubler syndrome, ipsilateral cranial nerve 6 and 7 palsy with contralateral hemiplegia, 1.5 syndrome, combination of internuclear ophthalmoplegia and conjugate gaze palsy, medial pontine syndromes, presenting with various combinations of cranial nerve deficits, ataxia, and contralateral paralysis. Superior cerebellar artery, SCA, nonspecific symptoms, nausea, vomiting, dizziness, ataxia, and horizontal nystagmus, lateral superior pontine syndrome, ipsilateral ataxia, nausea, vomiting, nystagmus, Horner's syndrome, and conjugate gaze paresis, contralateral loss of pain and temperature sensation, posterior cerebral artery, PCA, visual field defects, contralateral homonymous hemianopsia and possible unilateral blindness, visual agnosia, inability to recognize objects, common after CPR. The occipital cortex is a watershed area vulnerable to hypoperfusion, motor function, typically minimally affected, midbrain syndromes, lateral midbrain syndrome, ipsilateral cranial nerve 3 palsy with contralateral hemiataxia. Medial midbrain syndrome, ipsilateral cranial nerve 3 palsy with contralateral paralysis, anterior inferior cerebellar artery, AICA, lateral inferior pontine syndrome, ipsilateral facial paralysis and loss of corneal reflex, ipsilateral loss of pain and temperature sensation on the face, nystagmus, nausea, vomiting, vertigo, and ipsilateral hearing loss. Ipsilateral limb and gait ataxia, ipsilateral Horner's syndrome, contralateral loss of pain and temperature sensation in the trunk. And extremities, posterior inferior cerebellar artery, pica, lateral medullary, Wallenberg syndrome, ipsilateral cerebellar signs, ataxia, vertigo, nystagmus, ipsilateral loss of pain and temperature sensation on the face. Ipsilateral Horner's syndrome, dysphagia, hoarseness, and dysarthria due to cranial nerve involvement, contralateral loss of pain and temperature sensation over the body, also caused by vertebral artery occlusion in most cases. As we continue our journey through the intricate landscape of stroke, it becomes evident that the brain's vast network can present with an array of clinical manifestations, each telling a unique story about the vascular territories involved. Let us delve deeper into some specific syndromes and assessment tools that are crucial for understanding and managing stroke patients effectively. Internal capsule and lacunar infarcts, the subtle saboteurs. Deep within the brain lies the internal capsule, a critical pathway where nerve fibers converge to relay information between the cortex and the spinal cord. Infarcts in this area, often termed lacunar strokes due to their small, lake-like appearance on imaging, can present subtly yet significantly. Clinical presentation, contralateral pure motor deficits. Infarcts in the posterior limb of the internal capsule can lead to pure motor weakness on the opposite side of the body, affecting both the face and body without sensory loss. Contralateral pure sensory deficits, thalamic infarcts, known as Dejerine-Roussy syndrome, result in pure sensory loss contralateral to the lesion. Combined deficits, larger infarcts may present with both motor and sensory deficits on the contralateral side, differentiating from cortical strokes, while lacunar strokes can mimic cortical strokes affecting the anterior cerebral artery (ACA) and middle cerebral artery (MCA) territories. Certain signs point towards a cortical origin. Gaze preference, deviation of eyes toward the side of the lesion is more characteristic of cortical strokes. Visual field defects, homonymous hemianopsia suggests cortical involvement. Aphasia, language disturbances occur with dominant hemisphere cortical lesions, particularly in MCA strokes. Spatial neglect, non-dominant hemisphere cortical lesions may lead to neglect of one side of the body or space. Other lacunar syndromes, ipsilateral ataxic hemiparesis, infarcts in the posterior limb of the internal capsule can cause ataxia predominantly in the legs more than the arms, combined with weakness. Dysarthria clumsy hand syndrome, infarcts in the basilar pons or anterior limb of the internal capsule result in slurred speech and clumsiness of the hand on the side opposite the lesion. Anterior spinal artery (ASA) syndromes, the spinal cord's vulnerable lifeline. The ASA supplies the anterior two-thirds of the spinal cord, and its compromise can lead to profound deficits. Superior ASA infarcts, medial medullary syndrome. This syndrome exhibits an alternating pattern of symptoms. Contralateral arm and leg weakness, due to corticospinal tract involvement, loss of proprioception and vibration sense. On the contralateral side, ipsilateral tongue deviation, the hypoglossal nerve is affected, causing the tongue to deviate toward the side of the lesion. Inferior ASA infarcts, ASA syndrome, often occurring in the watershed area between T4 and T8. This syndrome presents with bilateral loss of pain and temperature sensation due to spinothalamic tract involvement affecting the trunk and extremities, bilateral motor weakness in the trunk and extremities from corticospinal tract compromise, preservation of dorsal columns, proprioception and vibration sense remain intact because the posterior spinal arteries supply these areas. EMS assessment and treatment, the front line of stroke management. Emergency medical services (EMS) play a pivotal role in the initial management of stroke patients. Their rapid assessment and intervention can significantly influence outcomes. Initial interventions, support ABCs, ensure airway, breathing, and circulation are maintained. Administer oxygen to maintain adequate oxygenation. Check glucose level. Hypoglycemia can mimic stroke symptoms. Perform stroke assessment. Utilize standardized tools like the Los Angeles Pre-Hospital Stroke Screen, LAPSS, or the Cincinnati Pre-Hospital Stroke Scale, CPSS, to evaluate for stroke signs, establish onset of symptoms. Determining the exact time when the patient was last known to be at their baseline is crucial for treatment decisions, particularly the administration of thrombolytics, rapid transport, Expedite transport to the nearest stroke center, bringing a family member if possible to. Provide additional history, hospital pre-alert, notify the receiving facility with a possible stroke patient alert to prepare the stroke team in advance, stroke workup, unveiling the culprit. Upon arrival at the hospital, a systematic workup is essential to confirm the diagnosis, identify the type of stroke, and rule out mimics, laboratory tests, point-of-care glucose, immediate assessment to rule out hypoglycemia, complete blood count, CBC to check for anemia or infection, chemistry panel. Electrolyte imbalances can affect neurological function, coagulation studies, prothrombin time, PT, international normalized ratio, INR, and activated partial thromboplastin time. APTT, assess bleeding risk, troponin levels, stroke and myocardial infarction can co-occur, type and screen, preparation for potential transfusion if needed, electrocardiogram, ECG, cardiac monitoring, detect arrhythmias like atrial fibrillation, which can be a source of emboli, ischemic changes, large intracerebral hemorrhages, ICH, or strokes may show deep T-wave inversions, prolonged QT intervals, or occasional ST segment changes, neuroimaging, non-contrast head CT, ischemic stroke, CT sensitivity is about 42%, but specificity is high at 91%, intracerebral hemorrhage. CT has near-perfect sensitivity, 95 to 100%. Purpose: to quickly identify hemorrhagic strokes and rule out stroke mimics like tumors or mass lesions. CT angiography, CTA, of the brain and neck, large vessel occlusion, identifies blockages amenable to thrombectomy. Carotid stenosis determines if urgent carotid endarterectomy is warranted. Additional considerations: pregnancy test in women of childbearing age to rule out pregnancy before imaging or interventions. Chest X-ray. CXR if infection is suspected or to evaluate for cardiac enlargement. Urinalysis, UA to check for urinary infections that might mimic or complicate stroke. Urine toxicology screen if substance ingestion is suspected as a cause. The Van score, a sharp eye for large vessel occlusion, early identification of patients with large vessel occlusions, LVOs, is critical, as they may benefit from mechanical thrombectomy in addition to thrombolytic therapy. Understanding the Van score. Van stands for vision, aphasia, neglect, requirement for Van positive, weakness present. There must be weakness, as evaluated by specific criteria. At least one of the Van symptoms must be present. Weakness qualifying findings: mild weakness, minor drift of an extremity, moderate weakness, severe drift, with the limb touching or nearly touching the ground, severe weakness, flaccidity or inability to lift against gravity. Vision qualifying findings: field cuts, loss of vision in specific quadrants, double vision, assessed by having the patient look left and right. Checking for uneven eye movements, new onset blindness, sudden loss of vision. Aphasia qualifying findings: expressive aphasia, inability to speak or errors in speech production. Paraphasias, excluding slurred speech. Assessment: ask the patient to repeat and name two objects. Receptive aphasia, difficulty understanding or following commands. Assessment: ask the patient to close their eyes or make a fist. Mixed aphasia, combination of both expressive and receptive difficulties. Neglect qualifying findings: force gaze deviation, inability to track eye movement to one side, sensory inattention, unable to feel stimuli on both sides simultaneously or unable to identify their own arm, ignoring one side, lack of awareness of one side of the body or environment. Action steps for Van positive patients: urgent imaging, order both CT and CTA of the head and neck. Treatment consideration: evaluate for thrombectomy and potential administration of tissue plasminogen. Activator, TPA. Pre-hospital stroke assessment, the first line of defense. Stroke care begins long before the patient reaches the hospital. Emergency medical services, EMS, personnel are often the first healthcare providers to interact with stroke patients, making their assessment skills crucial. Two widely used pre-hospital stroke screening tools are the Los Angeles Pre-Hospital Stroke Screen, LAPSS, and the Cincinnati Pre-Hospital Stroke Scale, CPSS. Let's delve into each. Los Angeles Pre-Hospital Stroke Screen, LAPSS. A systematic approach. The LAPSS is designed to identify stroke patients in the field accurately. It involves a series of screening criteria that, when all answered affirmatively, strongly suggest a stroke. Screening criteria: age over 45 years, no prior history of seizure disorder, onset of new neurological symptoms within the last 24 hours, patient was ambulatory before the event, blood glucose level between 60 and 400 mg per deciliter. Examination reveals unilateral weakness. Examination details: facial smile, grimace, look for asymmetry, does one side droop, grip strength, assess for weak or absent grip on one side, arm weakness, observe for drift or rapid fall of one arm. If the answer is yes to all the screening criteria and unilateral weakness is present, the LAPSS criteria are met. EMS should then notify the receiving hospital with a code stroke alert. Note: even if the LAPSS criteria are not fully met, a stroke can still be occurring. Clinical judgment should always be exercised. Cincinnati Pre-Hospital Stroke Scale, CPSS. Simplicity and speed. The CPSS is a straightforward tool focusing on three key physical findings that are quick to assess: facial droop, normal, both sides of the face move equally; abnormal, one side of the face does not move as well as the other; arm drift, normal, both arms move equally or not at all; abnormal, one arm drifts down compared to the other when both arms are extended. Speech, normal, the patient uses correct words with no slurring; abnormal, slurred speech, inappropriate words, or inability to speak. Note: any abnormal finding in the CPSS suggests the possibility of a stroke and warrants immediate action, immediate assessment and stabilization, setting the foundation. Upon arrival at the scene or emergency department, the immediate priorities are stabilization and rapid assessment to determine the next steps. Essential steps: check airway, breathing, and circulation. ABCs ensure the patient has a patent airway, is breathing adequately, and has sufficient circulation. Vital signs monitoring, continuous monitoring to detect any changes. Administer oxygen. If the patient is hypoxemic, provide supplemental oxygen to maintain adequate saturation. Start intravenous for fluids. Establish for access for medication administration and fluid management. Obtain blood samples for laboratory analysis, including glucose levels, which can mimic stroke symptoms if abnormal. 12. Lead electrocardiogram (ECG) to identify any cardiac arrhythmias or ischemia that may contribute to or result from the stroke. Check blood glucose level. Correct any hypoglycemia or hyperglycemia promptly. Perform general neurological screening, a rapid assessment to determine the severity and location of deficits. Activate the stroke team. Early notification ensures that specialists are ready to intervene as soon as possible. Initiate emergency brain imaging. An urgent CT scan or MRI is critical to distinguish between ischemic and hemorrhagic. Immediate neurologic assessment by the stroke team. Precision and expertise. Once stabilized, a detailed neurologic assessment is conducted by the stroke team to guide further management. Key components: review patient history, gather information about symptom onset, medical history, medications, and any potential contraindications to therapies. Establish onset of symptoms. Accurate timing is crucial, especially for time-sensitive interventions like thrombolysis. Perform neurologic examination. Utilize standardized tools like the National Institutes of Health Stroke Scale, NIHSS, or the Canadian Neurologic Scale to quantify the patient's deficits, decision point, imaging results and management pathways. The results of the emergency brain imaging guide the subsequent course of action. The primary goal is to determine whether the stroke is ischemic or hemorrhagic. Scenario 1. No hemorrhage detected. Probable ischemic stroke. Review fibrinolytic exclusions. Assess for any contraindications to thrombolytic therapy, such as recent surgery, bleeding disorders, or severe uncontrolled hypertension. Repeat neurologic examination. Determine if deficits are improving spontaneously. If deficits are improving, the patient may not be a candidate for fibrinolytics. Consider administering aspirin and begin the standard stroke care pathway. Candidate for fibrinolytic therapy, yes, if no exclusions are present and the patient is within the therapeutic window, less than 3 to 5 hours from symptom onset. Proceed with treatment. Discuss risks and benefits. Engage in shared decision-making with the patient and family. Administer recombinant tissue plasminogen activator, RTPA. Adhere to dosing protocols and monitor closely. Avoid anticoagulants or antiplatelets for 24 hours to reduce the risk of bleeding complications. Begin stroke pathway. Implement comprehensive care, including monitoring, rehabilitation planning, and secondary prevention strategies. Note on extended window. For patients over 80 years old with severe strokes, NIHSS score greater than 25, taking oral anticoagulants, or with a history of diabetes and prior ischemic stroke, the window for RTPA administration is limited to less than 3 hours. Scenario 2. Hemorrhage present on imaging. Hemorrhagic stroke management. RTPA contraindicated. Thrombolytic therapy is not used in hemorrhagic strokes due to the risk of exacerbating bleeding. Consult neurologist or neurosurgeon. Immediate specialist input is required for potential surgical interventions or specialized medical management. Consider transfer if neurology or neurosurgery services are unavailable. Arrange for prompt transfer to an appropriate facility. Begin hemorrhage pathway. Admit to stroke unit or intensive care unit, ICU, for close monitoring and management. Monitor blood pressure. Hypertension can worsen bleeding. Manage according to guidelines. Manage blood glucose levels. Both hyperglycemia and hypoglycemia can adversely affect outcomes. Initiate supportive therapy. Address airway protection, ventilation, and other supportive measures as needed. Monitor neurologic status. Frequent reassessment to detect any deterioration. Emergency CT if worsening. Rapid imaging if the patient's condition declines to identify potential complications like rebleeding or hydrocephalus. A general care for the stroke patient, laying the foundation for recovery once a stroke is suspected or confirmed. Meticulous general care is essential to stabilize the patient and prepare for definitive treatments. Key steps in general care. Ensure a patent airway. Assess for any obstructions. Be prepared to provide advanced airway management if necessary. Monitor vital signs. Continuous monitoring of blood pressure, heart rate, respiratory rate, and oxygen saturation. Detect and address any deviations promptly. Rule out trauma or other medical causes. Perform a thorough examination to exclude conditions that can mimic stroke, such as seizures, hypoglycemia, or drug intoxication. Check blood glucose level. Hypoglycemia and hyperglycemia can both present with neurologic symptoms. Correct any abnormalities promptly to avoid further neurologic injury. Administer thiamine, vitamin B1. Dosage: 100 mg intravenously, intramuscularly, or subcutaneously. Indication: particularly important for malnourished patients or those with chronic alcoholism to prevent Wernicke's encephalopathy. Avoid excess intravenous fluids and dextrose solutions. D5W. Overhydration can exacerbate cerebral edema. Dextrose-containing solutions can worsen hyperglycemia. Administer acetaminophen if febrile. Fever can increase metabolic demand and exacerbate neuronal injury. Dosage: as per hospital protocol, ensuring no contraindications. Prepare for rapid transfer to a stroke facility, if not already in a specialized center. Expedite transfer to ensure access to advanced interventions. Provide supplemental oxygen. Maintain adequate oxygenation to prevent hypoxia-induced neuronal damage. Keep the patient NPO, nothing by mouth. Risk of aspiration is high due to potential swallowing difficulties. Await formal swallowing assessment before initiating oral intake. Imaging studies, the window into the brain, non-contrast. Computed tomography, CT, scans. A non-contrast CT scan is the cornerstone of acute stroke imaging, allowing rapid differentiation between ischemic and hemorrhagic strokes and identifying other potential intracranial pathologies. Findings in different stroke types: ischemic stroke, clinical presentation, focal neurologic deficits, possible headache, altered level of consciousness, LOC. CT findings may initially appear normal in the hyperacute phase. Subtle signs like loss of gray-white matter differentiation or hyperdensity in affected areas, e.g., left parietal region, intracerebral hemorrhage, ICH. Clinical presentation, decreased LOC, major neurologic deficits, severe headache, CT findings. Hyperdense, bright, areas indicating acute blood accumulation, e.g., right parietal hemorrhage. Note, fibrinolytics are contraindicated in ICH, subarachnoid hemorrhage, SAH, clinical presentation. Sudden onset, often during exertion, described as the worst headache of my life, may have stiff neck, nausea, vomiting, without significant LOC alteration, CT findings, blood visible in the subarachnoid spaces. Note, fibrinolytics are contraindicated in SAH, subdural hematoma. Clinical presentation, decreased LOC, drowsiness, headache, unequal or dilated pupils, nausea, vomiting, agitation, confusion, CT findings, crescent-shaped collection along the brain's surface. Note, fibrinolytics are contraindicated in subdural hematoma. Blood pressure management, navigating the delicate balance, blood pressure, BP control in acute stroke is a critical aspect of management. The goals vary depending on the stroke type and treatment considerations. BP goals in acute stroke, stroke type for TPA eligible, target BP less than 185 is 110. BP must be lowered below this threshold before administering TPA. After TPA administration less than 180 to 105, monitor BP every 15 minutes for 2 hours, then every 30 minutes for 6 hours. Then hourly until 24 hours post-TPA. No TPA planned less than 220/120. Permissive hypertension is allowed to maintain cerebral perfusion unless BP exceeds this threshold. Mechanical thrombectomy less or equal to 180 to 105. Maintain target BP during and for 24 hours after the procedure. Aneurysmal subarachnoid hemorrhage, unsecured aneurysm SBP less than 140/160. Controversy exists regarding the exact target. Some recommend maintaining mean arterial pressure, MAP. Common medications for BP control in acute stroke. Several antihypertensive agents are used to achieve BP goals in acute stroke. Selection depends on the urgency, patient comorbidities, and potential side effects. Medications and guidelines. Labetalol, typical dose range, 10 to 20 mg intravenous, for push, may repeat once. Onset of action at approximately 5 minutes. Cautions and contraindications. Avoid in patients with chronic obstructive pulmonary disease, COPD, asthma, heart failure, bradycardia, or heart block. Nicardipine, typical dose range, start for infusion at 5 mg per hour, titrate up by 2.5 mg per hour every 5 to 15 minutes, maximum 15 mg per hour. Onset of action, 1 to 5 minutes. Cautions and contraindications. Avoid in severe aortic stenosis due to risk of worsening myocardial oxygen supply-demand balance. Clevidipine, typical dose range, begin at 1 to 2 mg hour 4, titrate by doubling the dose every 2 to 5 minutes, maximum 21 mg per hour. Onset of action, rapid onset of 2 to 4 minutes with a very short half-life. Cautions and contraindications. Avoid in patients with allergies to eggs or soy products, Use caution due to lipid emulsion vehicle, which provides extra calories. Hydralazine, typical dose range 10 to 20 mg. 4. Repeat every 4 to 6 hours as needed. Onset of action 10 to 20 minutes. Cautions and contraindications: variable and unpredictable BP response. Use with caution due to potential for reflex tachycardia and increased intracranial pressure. Whether patients are candidates for tissue plasminogen activator, TPA, or not, certain general care principles are universally applicable. General care for all ischemic stroke patients: prevent dehydration, ensure adequate fluid intake while avoiding overhydration, maintain euvolemia to support optimal cerebral perfusion, maintain oxygen saturation above 92%, provide supplemental oxygen if necessary. Hypoxia can exacerbate neuronal injury. Regulate blood glucose levels. Aim for blood glucose between 140 and 180 mg per deciliter. Both hyperglycemia and hypoglycemia can worsen neurologic outcomes. Prevent fever. Administer antipyretics like acetaminophen if the patient is febrile. Fever increases metabolic demand and can intensify brain injury. Head of bed elevation. Keep the head of the bed elevated at greater than 30 degrees. Promotes venous drainage and reduces intracranial pressure. TPA candidates. Embracing timely intervention for patients eligible for thrombolytic therapy. Additional considerations come into play, especially concerning blood pressure management, hypertension management prior to TPA administration. Blood pressure goals: lower systolic blood pressure, SBP, to less than 185 mm of mercury. Reduce diastolic blood pressure, DBP, to less than 110 mm of mercury. Aim for a mean arterial pressure, MAP, of less than 130 mm of mercury. Medication options: labetalol, dosage 10 to 20 mg for over 1 to 2 minutes, may repeat once. Mechanism: beta blocker that reduces heart rate and vascular resistance. Nitroglycerine paste, dosage: apply 1 to 2 inches to the skin. Mechanism: vasodilator that helps lower blood pressure. Nicardipine, dosage: start at 5 mg per hour for infusion. Titration: increase by 2.5 mg per hour at 5 to 15-minute intervals. Maximum dose of 15 mg per hour. Adjustment: once target blood pressure is achieved, reduce infusion to 3 mg per hour. Mechanism: calcium channel blocker that relaxes vascular smooth muscle. TPA administration. Balancing risks and benefits. Landmark trials and guidelines. NINDS trial, National Institute of Neurological Disorders and Stroke. Treatment window: patients treated within 3 hours of symptom onset. Benefits: 12% absolute risk reduction in disability at 3 months post-stroke. Number needed to treat: NNT 8 to 9 patients to benefit 1. Fewer patients discharged with severe disability. Risks: 1% increase in mortality, 5% increase in non-fatal intracranial hemorrhage. ECOS trial, European Cooperative Acute Stroke Study. Extended treatment window, up to 4.5 hours after symptom onset. Findings: confirmed the benefits observed in the NINDS trial even with the extended window. Guideline updates: the American Heart Association to American Stroke Association. AHA, ASA, now recommend TPA for eligible patients presenting up to 4.5 hours after symptom onset. Essential evaluations before TPA administration. Prior to initiating TPA, certain studies and evaluations are mandatory to ensure patient safety and optimize outcomes. Required assessments: physical examination. Utilize the NIH stroke scale to quantify neurologic deficits, head CT scan, non-contrast imaging to rule out hemorrhagic stroke or other contraindications, laboratory tests, complete blood count, CBC, check hemoglobin and platelet count. Platelets must be adequate for safe TPA administration. Coagulation studies, prothrombin time, PT, partial thromboplastin time, PTT. International Normalized Ratio (INR) necessary if there is suspicion of coagulopathy, recent heparin or warfarin. Use, or if anticoagulant status is unknown. Note, if no suspicion, treatment should not be delayed awaiting these results. Blood glucose, hypoglycemia can mimic stroke symptoms, hyperglycemia can worsen outcomes. Electrocardiogram, ECG, identify any cardiac arrhythmias or ischemia that may influence management. Urine pregnancy test, pregnancy is a relative contraindication, risks and benefits must be weighed. Fibrinolytic therapy checklist. Ensuring safety and efficacy. Before administering TPA, a thorough checklist must be completed, confirming inclusion and exclusion criteria. Inclusion criteria. All must be yes, age 18 years or older, clinical diagnosis, ischemic stroke causing measurable neurologic deficit. Time since symptom onset, less than 4.5 hours before treatment begins. Note, if any of the following are present, age over 80, severe stroke, NIHSS score more than 25, taking oral anticoagulants, history of diabetes and prior ischemic stroke, the window is less than 3 hours. Exclusion criteria, all must be no, recent stroke or head injury, within the past 3 months, intracranial hemorrhage, evidence on non-contrast CT, suspicion of subarachnoid hemorrhage, even if CT is normal, recent. Arterial puncture, within 7 days at a non-compressible site, large infarct on CT, multilobar infarction involving more than 1/3 of the cerebral hemisphere, uncontrolled hypertension, SBP more than 185 or DBP more than 110. Active internal bleeding or acute trauma, including fractures, bleeding diathesis, platelet count less than 100,000 mm³, heparin received within 48 hours with elevated APTT, current use of anticoagulants with elevated PT more than 15 seconds or INR more than 1.7, blood glucose level less than 50 mg per deciliter, history of intracranial hemorrhage, AV malformation, aneurysm or neoplasm. Relative contraindications, weigh risks versus benefits, minor or rapidly improving stroke symptoms, major surgery or serious trauma within the last 14 days, gastrointestinal or urinary tract hemorrhage within 21 days, recent acute myocardial infarction within 3 months, witness seizure at stroke onset with postictal impairments, administration of alteplase, TPA protocols and precautions. Dosing guidelines, total dose 0.9 mg per kilogram for maximum of 90 mg total. Diet, administration, bolus, 10%. Of the total dose given as an initial bolus over 1 to 2 minutes, infusion, the remaining 90% infused over 60 minutes, monitoring and post-administration care, neurological checks, every 15 minutes for the first 2 hours. Monitor for any signs of neurological deterioration or hemorrhage, blood pressure management, maintain SBP less than 180 mm of mercury and DBP less than 105 mm of mercury. If BP exceeds targets, nicardipine, 5 mg per hour for infusion, increase by 2.5 mg per hour every 15 minutes as needed, not to exceed 15 mg per hour. Labetalol, option 1 10 mg for over 1 to 2 minutes, may repeat every 10 to 20 minutes, maximum 300 mg. Option 2 10 mg for followed by continuous infusion at 2 to 8 mg a minute. If uncontrolled, consider nitroprusside infusion 0.5 to 10 mcg kilogram a minute with continuous arterial monitoring. Precautions: avoid anticoagulants and antiplatelets for 24 hours. Do not administer aspirin, heparin, or any other anticoagulants during this period to reduce bleeding risk. Post-TPA imaging: obtain a follow-up CT scan before starting antiplatelet or anticoagulant medications after the 24-hour period. Special considerations: navigating complex scenarios, heparin, and anticoagulation. Do not administer heparin acutely if TPA has been given. Assess the need for anticoagulation on a case-by-case basis after the initial 24 hours. Aspirin administration. If TPA is not given, aspirin may be started within 24 to 48 hours of stroke onset. If TPA is administered, delay aspirin for at least 24 hours. TPA complications. Navigating the risks of thrombolytic therapy. While TPA has revolutionized the treatment of acute ischemic stroke by restoring cerebral blood flow, it carries risks that must be carefully monitored. The two most significant complications are post-TPA hemorrhage and angioedema. Post-TPA hemorrhage, recognizing and responding swiftly, an intracerebral hemorrhage (ICH) after TPA administration is a life-threatening emergency. Early detection hinges on vigilant monitoring for specific clinical signs suggestive of post-TPA hemorrhage, decreased level of consciousness, LOC, any sudden decline in alertness or responsiveness, worsening neurological examination, new deficits or deterioration of existing symptoms. Increased weakness, particularly if it's sudden or progressive, new onset headache, severe or different from prior headaches, sudden rise in blood pressure, indicative of increased intracranial pressure. Other signs, gastrointestinal bleeding or mucosal bleeding, e.g., gums, nose. Immediate management steps. Stop TPA immediately. Action: discontinue the TPA infusion at the slightest suspicion of hemorrhage. Rationale: prevents further bleeding and limits damage. Obtain an urgent head CT scan. Purpose: confirm or rule out intracerebral hemorrhage. Note: time is critical. Expedite imaging. Resume TPA if no bleeding is detected. Decision: only if the CT scan is negative and the patient's condition allows. If intracerebral hemorrhage is confirmed, baseline laboratory tests, complete blood count, CBC, evaluate hemoglobin and platelet levels, D-dimer and fibrinogen levels, assess coagulation status, type and screen, prepare for potential transfusions. International Normalized Ratio (INR) check 15 minutes after fresh frozen plasma. FFP administration, platelet count. Reassess 15 minutes after platelet transfusion. Administer cryoprecipitate. Dosage: 10 units intravenously for fibrinogen replacement. Monitoring: recheck fibrinogen levels. If greater than 150 mg per deciliter, discontinue. If 1.4, consider an extra 20 ml per kilogram. Administer platelets. Dosage: 2 to 5 units. Goal: achieve platelet count 100,000 mm³. If counts remain low, administer additional units as needed. Consult neurosurgery immediately. Action: engage neurosurgical services for potential interventions. Consider tranexamic acid, TXA. Dosage: 15 mg per kilogram for infused in 250 ml over 20 minutes. Indication: if bleeding persists despite initial measures. Angioedema. Addressing a rare but serious reaction. Angioedema, particularly orolingual angioedema, is a rare adverse effect of TPA, potentially leading to airway obstruction. Management based on severity. A mild to moderate angioedema without airway compromise. First-line medications: antihistamines, diphenhydramine, 25 to 50 mg for, cetirizine, 10 mg orally, corticosteroids, methylprednisolone, 125 mg for, prednisone, 40 to 60 mg orally, H2 blockers, optional, ranitidine, 50 mg for, famotidine, 20 mg for, bradykinin-specific treatments, icatibant, if available. Dosage: 30 mg. Subcutaneously. Mechanism: blocks bradykinin B2 receptors to reduce swelling. Fresh frozen plasma. FFP. Dosage: 2 units for. Mechanism: provides enzymes to degrade excess bradykinin. C1 esterase inhibitors, e.g. Berinert. Indication: particularly for hereditary angioedema or refractory cases. Monitoring: admit to a monitored setting, close observation for potential airway compromise. Severe angioedema with airway compromise, emergency airway management, immediate actions, call for anesthesiology or ENT, prepare for possible intubation or surgical airway, e.g., cricothyrotomy. Use airway adjuncts, nasopharyngeal or oropharyngeal devices as temporizing measures, adrenaline, epinephrine, intramuscular injection, dosage 0.3 to 0.5 mg, 1 to 1000 concentration into the lateral thigh, repeat, every 5 to 15 minutes as necessary. Additional treatments, icatibant or FFP. Administer urgently if not previously given, nebulized epinephrine, dosage 5 ml of 1 to 1000 solution diluted in saline, administration via nebulizer to reduce airway edema. Management strategies for non-TPA candidates. For patients who are ineligible for TPA, either due to contraindications or time constraints, alternative management focuses on supportive care and secondary prevention. Blood pressure management, permissive hypertension, rationale allows for adequate cerebral perfusion to ischemic penumbra, thresholds for intervention. Systolic BP greater than 220 mm of mercury or diastolic BP greater than 120 mm of mercury. Reduction strategy, goal, lower BP by 15 to 25% over the first 24 hours. Preferred agent, nicardipine infusion is commonly used. Mean arterial pressure, MAP, target, maintain MAP. Endovascular therapy, expanding treatment horizons. In select patients with large vessel occlusions, mechanical thrombectomy offers a potential for improved functional outcomes. Mechanical clot retrieval, indications, large vessel occlusions, LVO, internal carotid artery, ICA, proximal middle cerebral artery, M1, basilar artery. Clinical trials and evidence, early trials, Mr. Rescue. Synthesis, IMS3, showed no significant benefit and possible harm. Mr. Clean trial, positive. Outcomes, increased functional independence at 90 days, functional independence rates, 32.6% with endovascular therapy versus 19.1% with standard care, intervention time frame, within 6 hours of symptom onset. Current AHA guidelines for mechanical thrombectomy, 0 to 6 hours post-symptom onset. Eligibility criteria, pre-stroke misses score 0 to 1, indicates minimal pre-existing disability, occlusion location, ICA or proximal M1 segment, age greater than or equal to 18 years, NIHSS score greater than or equal to 6, treatment initiation, arterial puncture within 6 hours. Consideration for M2 or M3 occlusions, selected patients may benefit based on individual assessment, 6 to 16 hours post-onset, dawn or diffuse 3 criteria, use advanced imaging to identify salvageable brain tissue, 16 to 24 hours post-onset, dawn criteria, careful patient selection is crucial, post-procedure blood pressure management, goal, maintain SBP. Central versus peripheral vertigo. Central and peripheral vertigo can both present suddenly, though central vertigo may also develop gradually. Peripheral vertigo typically involves an intense spinning sensation, while central vertigo tends to be less intense and more ill-defined. The pattern of peripheral vertigo is often paroxysmal and intermittent, contrasting with the continuous nature of central vertigo. Positional aggravation is common in peripheral vertigo but varies in central vertigo. Nausea and vomiting are common in peripheral vertigo but are variable in central cases. Nystagmus in peripheral vertigo appears as horizontal and unidirectional, whereas in central vertigo, it can be vertical or multidirectional. Symptoms of peripheral vertigo tend to fatigue over time, but those of central vertigo remain persistent. Hearing loss or tinnitus may be present in peripheral vertigo but are rarely seen in central vertigo. Lastly, CNS symptoms are usually absent in peripheral vertigo but are typically present in central vertigo. The HINTS examination, a tool for differentiation. The head impulse, nystagmus, test of skew, HINTS exam is a bedside assessment that helps distinguish central from peripheral causes of vertigo in patients with acute vestibular syndrome. Components of the HINTS exam. Head impulse test assesses vestibulo-ocular reflex, peripheral vertigo, abnormal, corrective saccade present. Central vertigo, normal response, nystagmus evaluation, peripheral vertigo, unidirectional, horizontal nystagmus, central vertigo, vertical, torsional, or direction-changing nystagmus, test of skew, assesses vertical ocular misalignment, peripheral vertigo, in negative, no skew deviation, central vertigo, positive skew deviation. Clinical significance, sensitivity and specificity. High sensitivity detects central causes when performed correctly. Comparison to MRI, a negative HINTS exam is more reliable than a negative MRI DWI in the first 24 to 48 hours after symptom onset. Usage guidelines, appropriate patient selection, criteria, acute persistent vertigo, nystagmus present. Normal neurological examination aside from vestibular findings, limitations, operator dependent, requires proper training and experience. Original study context, conducted by neuro-ophthalmologists, not extensively validated in emergency department settings. The HINTS examination, deciphering dizziness. The HINTS exam comprises 3 components, each shedding light on the underlying pathology. Head impulse test, HIT, reassuring finding, an abnormal result, characterized by a corrective saccade. Procedure, ask the patient to fix their gaze on your nose, rapidly and unpredictably turn their head about 15 degrees to one side, then the other. Observe whether their eyes maintain focus or if a corrective saccade occurs. Interpretation, peripheral vertigo, an abnormal hit with a corrective saccade when turning toward the affected side indicates a vestibular ocular reflex, VOR, failure, reassuring for a peripheral cause. Central vertigo, a normal hit, no corrective saccade, may suggest a central lesion, as the reflex pathways are intact. Nystagmus assessment, reassuring finding, unidirectional, horizontal nystagmus that remains consistent regardless of gaze direction. Procedure, observe the patient's eyes in primary gaze, then as they look to the left and right, note the direction and type of nystagmus. Interpretation, peripheral vertigo, nystagmus is typically horizontal and beats in one direction, away from the affected ear, and may increase when gazing in the direction of the fast phase. Central vertigo, presence. A vertical, torsional, or direction-changing nystagmus is concerning for a central cause. Test of skew, reassuring finding, no skew deviation upon alternate eye covering. Procedure, instruct the patient to focus on your nose, cover one eye for a few seconds, then rapidly uncover it while covering the other eye. Observe for any vertical corrective movement of the uncovered eye. And interpretation, peripheral vertigo, absence of skew deviation is reassuring. Central vertigo, a vertical misalignment. Skew deviation suggests brainstem involvement. Applying and interpreting the HINTS exam, it's essential to use precise terminology when documenting HINTS findings. Instead of saying HINTS negative, specify whether the results indicate a central or peripheral lesion. Peripheral, reassuring findings. Head impulse test, abnormal, presence of corrective saccade, nystagmus, unidirectional, horizontal, test of skew, no skew deviation. Central, concerning findings. Head impulse test, normal, no corrective saccade, nystagmus, vertical or direction changing. Test of skew, presence of skew deviation. Remember, specify the exact findings for clarity and accurate communication. Patient selection for the HINTS exam. Inclusion criteria, patients presenting with acute vestibular syndrome. Sudden onset of persistent vertigo, nystagmus, and normal neurological examination except for vestibular findings. At least one stroke risk factor, such as atrial fibrillation, hypertension, diabetes, hyperlipidemia, smoking, prior stroke or myocardial infarction, hypercoagulable states, recent cervical trauma, eclampsia, exclusion criteria, history of recurrent vertigo with or without auditory symptoms, e.g., Meniere's disease. Efficacy of the HINTS exam, sensitivity and specificity. A positive HINTS exam is 100% sensitive and 96% specific for detecting a central lesion, more sensitive than early MRI with diffusion-weighted imaging, DWI, in the first 24 to 48 hours after symptom onset. Clinical implications. Early identification of central causes allows for prompt neurosurgical consultation, essential to prevent rapid deterioration due to potential herniation in brainstem strokes, transient ischemic attack. Forewarning, moving forward, let's discuss the critical concept of a transient ischemic attack, TIA, often a harbinger of impending stroke. Definition. Modern definition, a brief episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without evidence of acute infarction, typically lasting less than 1 hour. Classical definition, neurological deficits lasting less than 24 hours, presumed vascular in origin. Significance, TIAs are akin to unstable angina in cardiac events. Approximately 15% of strokes are preceded by a TIA, underscoring the need for urgent evaluation. Clinical features, focal weakness, unilateral paralysis or weakness, speech impairments, dysarthria, dysphasia, or aphasia, visual changes, field deficits, blindness or double vision, coordination issues, ataxia or balance disturbances. Management, risk stratification, utilize tools like the ABCD² score to assess stroke risk. Low risk score. Hemorrhagic stroke, a battle within. Lastly, let's delve into hemorrhagic strokes, which pose unique challenges in diagnosis and management. Overview, also referred to as a spontaneous intracerebral hemorrhage, comprises about 10% of all acute strokes. Risk factors, hypertension, the most significant contributor. Anticoagulant use, warfarin, increases risk substantially. Each 0.5 increase in INR above 4.5 doubles the risk. Other anticoagulants and antiplatelet agents also elevate risk. Clinical presentation, similarities to ischemic stroke and SAH, sudden onset of neurological deficits, may be difficult to distinguish based solely on symptoms. Features suggestive of hemorrhage. Severe headache, often preceding neurological deficits. Vomiting, due to increased intracranial pressure, ICP. Elevated blood pressure, systolic BP often exceeding 220 mm of mercury. Decreased level of consciousness, rapid decline may occur. Symptom progression, worsening over minutes to hours. Common bleeding sites and associated symptoms. Putamen, most common. Contralateral motor deficits, thalamus, sensory loss greater than motor deficits. Ponce, deep coma, pinpoint pupils, cerebellum. Ataxia, difficulty walking, vertigo. Management strategies, airway and breathing, ensure airway protection, provide oxygen to maintain saturation, blood pressure control, target SBP. Reverse anticoagulation, warfarin reversal, vitamin K, administer 10 mg for prothrombin complex concentrate, PCC for rapid INR correction, direct oral anticoagulants, use specific reversal agents if available, surgical intervention, indications, cerebellar hemorrhage greater than 3 cm with neurologic deterioration. Hydrocephalus from ventricular obstruction, lobar hemorrhage in select cases. Prognosis, ICH score, utilized to predict mortality. Factors include GCS score, hematoma volume, presence of intraventricular hemorrhage, age, and infratentorial origin. Outcomes, early aggressive management may improve functional recovery, reversing coagulopathy, restoring the delicate balance. In the management of hemorrhagic strokes and other bleeding emergencies, reversing anticoagulation is often a life-saving measure. Understanding the nuances of various anticoagulants and their reversal agents is essential for timely and effective intervention. Factor XA inhibitor reversal. Common factor XA inhibitors: apixaban, Eliquis, edoxaban, Cerveza, rivaroxaban, Xarelto, fondaparinux, Arixtra. Key considerations: half-life ranges from 8 to 21 hours, prolonged in renal impairment, dialysis removal, generally not effective, except partially with edoxaban, (25%). Reversal strategies: activated charcoal. If ingestion occurred within the last 2 hours, 4-factor prothrombin complex concentrate, PCC, Ikentra. Apixaban, edoxaban, rivaroxaban, 25 units kilogram E max 2,500 units, for intracranial hemorrhage, 50 units kilogram E max 5,000 units, for other life-threatening bleeds, fondaparinux, 50 units kilogram E max 5,000 units. Andexanet alpha, a targeted antidote. Overview: FDA approval, granted in May 2018. Mechanism: acts as a decoy receptor for factor XA inhibitors. Clinical trial insights showed reduction in anti-factor XA activity. 82% of patients achieved excellent hemostasis. However, high mortality rate, 14% at 30 days, and lack of a control group limit the robustness of the evidence. Dosing regimens: low dose, 400 mg for bolus at 30 mg a minute, followed by infusion of 4 mg per minute for up to 120 minutes. High dose, 800 mg for bolus at 30 mg a minute, followed by infusion of 8 mg per minute for up to 120 minutes. Direct thrombin inhibitor reversal. Common agents: dabigatran, Pradaxa, argatroban, bivaludin, Angiomax. Key considerations: half-life, dabigatran, 14 to 17 hours, extended in renal impairment. Argatroban and bivaludin, shorter half-lives. Dialysis removal: dabigatran, approximately 65% removed via hemodialysis. Reversal strategies: activated charcoal, if ingestion occurred within 2 hours. Idarucizumab, Praxbind. Dosage: 5 grams for. Indication: specific antidote for dabigatran. Hemodialysis: consider in patients with end-stage renal disease. Heparin reversal: types of heparins. Unfractionated heparin, UFH, low molecular weight heparins, LMWH, enoxaparin, Lovenox, dalteparin, Fragmin. Reversal strategies: protamine sulfate, unfractionated heparin. Dosage: 50 mg for immediate reversal. LMWH. Dosage: protamine neutralizes about 60% of LMWH activity. Guidelines: if 12 hours, unlikely to be effective unless renal impairment is present. Monitoring: obtain baseline anti-XA activity levels, repeat levels to assess reversal efficacy. Warfarin reversal: management based on INR and clinical scenario. Serious or life-threatening bleed, any INR, hold warfarin, administer vitamin K, 10 mg for infusion over 30 minutes, provide FFP or for factor PCC, Ikentra, PCC preferred for rapid reversal. INR greater than 10 without bleeding, hold warfarin, consider vitamin K, 2.5 mg orally or 1 to 2 mg for INR 4.5 to 10 without bleeding, hold warfarin. Consider vitamin K, 2.5 mg orally, need for rapid reversal, administer vitamin K as above based on urgency. Tranexamic acid, a hemostatic agent, usage, consider in hemorrhagic events within 3 hours of onset. Dosage: loading dose, 1 gram for. Maintenance, 1 gram infused over 8 hours. Antiplatelet agent reversal, agents, aspirin, clopidogrel, prasugrel. Reversal strategies: desmopressin, DDAV. Dosage: 0.3 micrograms per kilogram for. Mechanism: promotes release of von Willebrand factor and factor VIII, platelet transfusion, indications, known thrombocytopenia, platelet count. Subarachnoid hemorrhage, the thunderclap of neurology. A subarachnoid hemorrhage, SAH, is a critical emergency characterized by bleeding into the subarachnoid space, often resulting from a ruptured aneurysm. Epidemiology and risk factors. Prevalence accounts for approximately 10% of patients presenting with a thunderclap headache. Risk factors, genetic predispositions, polycystic kidney disease, Ehlers-Danlos syndrome, family history of aneurysms, lifestyle factors, hypertension, smoking, alcohol consumption, cocaine use, others, age over 50, estrogen deficiency, etiology, ruptured cerebral aneurysm, 85%, often located at arterial bifurcations in the circle of Willis. Non-aneurysmal causes, 15%, perimesencephalic hemorrhage, arteriovenous malformations, coagulopathies, tumors, venous sinus thrombosis. Clinical presentation, sudden, severe headache, described as the worst headache of my life, reaches maximal intensity within minutes. Associated symptoms, syncope or seizures, due to abrupt increase in intracranial pressure, nausea and vomiting. Commonly accompany the headache. Meningeal signs, neck stiffness may develop hours after onset. Visual disturbances, photophobia, vision loss, altered consciousness, ranges from confusion to coma. Retinal hemorrhages may be detected on fundoscopic examination, especially in comatose patients. Sentinel headaches occur in up to 50% of patients days to weeks before the major hemorrhage, result from minor leaks of blood. One of the tools that have been developed to aid in this process is the Ottawa SAH rule. Ottawa SAH rule, a guiding light. The Ottawa SAH rule is designed to help clinicians identify patients who are at low risk for SAH and may not require further invasive testing. It's important to note, however, that this rule has not been externally and prospectively validated, and the authors themselves caution against its routine implementation without further evidence, sensitivity and criteria. The rule boasts a 100% sensitivity for ruling out SAH, with a confidence interval of 97.1% to 100%. SAH can be excluded if all of the following criteria are met: age less than 40 years, no neck pain or stiffness, no witnessed loss of consciousness, no onset during exertion, no thunderclap headache, defined as instantly peaking pain, no limited neck flexion on physical, clinical application. Caution is advised, given the lack of external validation. The rule should be applied judiciously. High suspicion if concern for SAH and a normal CT, particularly if the CT was obtained more than 6 hours after symptom onset. Lumbar puncture strongly considered. Diagnostic imaging, the window into the brain. Non-contrast head CT scan. Sensitivity varies with time. Less than 6 hours from onset, approximately 100% sensitive. 6 to 12 hours, about 98% sensitivity. 12 to 24 hours, drops to 93% sensitivity. 24 hours to 5 days, sensitivity decreases significantly to less than 60%. Interpretation nuances. Aneurysmal SAH. Look for blood in the cisterns, especially the suprasellar cistern. Traumatic SAH. Blood is often seen over the convexities of the frontal and temporal lobes. Lumbar puncture. The decisive step, when to perform, if the CT scan is negative but clinical suspicion remains high. Key findings: elevated red blood cell (RBC) count that does not diminish from tube 1 to tube 4 suggests SAH. Note: a decreasing RBC count can still occur in SAH. A normal RBC count in the final tube is more reassuring. Opening pressure, often elevated, greater than 20 cm HO, in about 60% of SAH cases, can help differentiate from a traumatic tap, which typically has a normal opening pressure. Xanthochromia, the yellowish discoloration of cerebrospinal fluid due to the breakdown of hemoglobin. Timing may take at least 2 hours to develop. highest sensitivity after 12 hours, diagnostic value E helps. Distinguish SAH from a traumatic tap, special considerations in lumbar puncture, traumatic tap suspicion, tube for RBC count 2000 mm³ combined with xanthochromia increases diagnostic sensitivity to 100%. CT angiography, CTA, alternative to LP, a CT scan followed by a CTA is an acceptable alternative when LP is contraindicated or declined. Sensitivity, approximately 98% sensitive for detecting aneurysms larger than 3 mm. Additional benefits, helps predict delayed cerebral ischemia by identifying vasospasm. Management of subarachnoid hemorrhage, a delicate balance. Effective management of SAH involves addressing physiological derangements while preventing complications, physiological optimization, avoid hypertension, maintain a mean arterial pressure, MAP, greater than 80 mm of mercury to ensure cerebral perfusion pressure, CPP, of at least 60 mm of mercury. Assuming intracranial pressure, ICP, is normal. Magnesium sulfate, controversial use, aimed at preventing vasospasm due to its NMDA receptor antagonism and calcium channel blocking effects. Target levels, maintain serum magnesium between 2 to 2.5 millimoles per liter. Seizure prophylaxis, controversial, some advocate for a short course, e.g., 3 days, of antiepileptic drugs. Options, levetiracetam, phenytoin, carbamazepine, or phenobarbital. Caution, phenytoin may be associated with worse neurological and cognitive outcomes. Glycemic control. Consideration, while evidence is mixed, maintaining euglycemia may be beneficial. Approach, use insulin sliding scales if the patient remains in the emergency department for extended periods. Head of bed elevation. Recommendation, keep the head of the bed elevated to reduce ICP and promote venous drainage. Definitive aneurysm treatment, surgical clipping, open surgical procedure to place a clip at the neck of the aneurysm. Endovascular coiling, minimally invasive technique where coils are inserted to induce clotting within the aneurysm. Antifibrinolytic therapy, usage. Considered if there is a delay in definitive aneurysm treatment, agents, tranexamic acid, TXA, or aminocaproic acid. Duration. Short-term therapy, typically less than 72 hours. Intubation, a neuroprotective approach. When intubation is necessary, minimizing increases in intracranial pressure is critical. Pre-intubation preparation. Medications administered 3 minutes before intubation, lidocaine, 1 to 2 mg/kg 4 to blunt the rise in ICP associated with laryngoscopy, fentanyl, 2 to 5 mcg/kg 4 as a sympatholytic to reduce the stress response. Sedation choices, etomidate, preferred if blood pressure is within normal limits due to its hemodynamic stability. Propofol, suitable if the patient is hypertensive, offers both sedation and blood pressure reduction. Neuromuscular blockade, succinylcholine, used without a defasciculating dose to avoid increases in ICP. Post-intubation management, pain control and sedation, ensure the patient remains pain-free. Use a combination of propofol and fentanyl, prioritizing analgesia. Blood pressure guidelines from the AHA for aneurysmal SAH, balancing act. BP management should aim to reduce the risk of rebleeding while ensuring adequate cerebral perfusion. Medication choices, nicardipine, labetalol, and esmolol are appropriate. Avoid sodium nitroprusside due to its potential to increase ICP. Complications. Navigating the challenges. Rebleeding, highest risk, within the first 24 hours, especially the initial 6 hours. Diagnosis, sudden deterioration in neurological status. Confirm with CT scan. Prevention, definitive aneurysm treatment is the only effective measure. Vasospasm, impact, leading cause of delayed death and disability post-SAH. Timing, typically begins around day 3 after the hemorrhage. Management, monitoring, vigilant neurological assessments. Treatment, initiated after securing the aneurysm. Options, Triple H therapy, hypertension, hypovolemia, hemodilution. Although evidence for benefit is limited, cardiac abnormalities, etiology, surge of catecholamines due to hypothalamic stress, manifestations, elevated troponin levels, ST segment depression, arrhythmias, including atrial fibrillation and torsades de pointes, prolonged QT interval and deep T-wave inversions. Hydrocephalus, cause, impaired cerebrospinal fluid absorption due to blood products, management, may require external ventricular drainage if there is a decline in consciousness not improving within 24 hours. Hyponatremia, prevalence, occurs in 10 to 40% of SAH patients in the ICU. Causes, cerebral salt wasting, leads to hypovolemia and hyponatremia. Syndrome of inappropriate antidiuretic hormone secretion, SIAD, causes euvolemic hyponatremia. Management requires careful assessment to differentiate between the two, as treatments differ. In conclusion, understanding stroke, from its pathophysiology to the importance of timely diagnosis and evidence-based management, is vital for improving patient outcomes. Recognizing early warning signs, employing advanced imaging techniques, and implementing multidisciplinary care strategies are the cornerstones of reducing the burden of this condition. As healthcare professionals, our role extends beyond treatment to include prevention and patient education, empowering individuals to make lifestyle changes that reduce their risk. Thank you for joining me on this journey to deepen our knowledge of stroke care. Your support means the world to me, so if you found this lecture helpful, please like, subscribe, and share to help us reach more healthcare professionals worldwide. Together, let's make a difference in the lives of our patients.